So dear members of the chair, dear audience, welcome to the 9-month progress report of my PhD thesis entitled The Role of Radioembolization in Patients with Liver Tumors. My name is Alexandra Adam. I am a 6th-year medical student and a first-year MD PhD student representing the Department of Interventional Radiology of Semmelweis University in Budapest. Our passionate team consists of my supervisors and my co-investigators, and throughout my future career, I would like to treat patients with liver tumor in a less invasive way by enhancing the role and impact of interventional radiology through the broader use of radioembolization in oncological therapies. To achieve these goals, I have two specific projects in the field of radioembolization. Regarding the first one, we would like to conduct the research in the form of a systematic review and meta-analysis, while regarding the second one, the applied methodology will be a retrospective cohort study. Both of them were started in the autumn of 2024. Now, I would like to talk about my first project in details, investigation of the effect of radiation lobectomy in patients with liver tumors. Liver cancer is the third most common tumor-associated cause of death worldwide, causing more than 800,000 deaths every year. Hepatocellular carcinoma is about 90% of primary liver malignancies. Moreover, liver is also one of the most frequent sites of metastasis, especially in the cases of patients with colorectal, pancreatic, or breast cancer history. The gold standard therapy for liver tumors is surgical resection, which is considered to be curative. However, as any other type of surgery, it also has its complications, namely the post-hepatectomy liver failure, being the main cause of mortality after a major liver resection. The reason of this liver failure is the small future liver remnant. You may ask, what is the future liver remnant? It is part of the liver that the patient will have after the surgery, so which hasn't been resected. And if the future liver remnant is not large enough, the liver will not be able to maintain its crucial functions and the patient could die. In order to prevent our patients from this liver failure, we would like them to undergo surgery with a sufficient large future liver remnant. And this sufficient increase can be achieved by the compensatory hypertrophy of the contralateral lobe, which can be induced either by radiation lobectomy or by different venous deprivation techniques, such as portal vein embolization or liver venous deprivation. And my biggest aim with conducting this research is to understand the effect of radioembolization as a bridge to surgery treatment. Therefore, our clinical question is radiation lobectomy safe and effective to increase liver hypertrophy in case of liver tumors? To structurize our research, we are using the PICO framework, where we are comparing the different interventions to address the following outcomes: future liver remnant hypertrophy, resection rate, and overall survival. The clinical implication of our research would be the improvement of resectability and overall survival. And if our hypothesis is correct and is confirmed, the results of our research can be directly translated to patients' care, and radiation lobectomy can serve as a substantial treatment prior to surgery. At this slide, you can see some of my key articles, which were used for the feasibility check of the topic. Most of the studies are observational studies, and due to the very low number of direct comparative studies, we are also pooling single-arm studies. The literature research was conducted in 4 different databases with the following search key, where domain 1 refers to the disease itself, and domain 2 to the different interventions. Altogether, we got more than 9,000 hits, and after the duplicate removal, the title abstract, and full text selection, 90 studies remained, and also we found additionally 5 more articles with the help of the citation chaser. Regarding the progress of my first project, I am halfway through the data extraction, which is planned to be finished in the middle of July. Now moving on to my second project, it is about investigating the safety and efficacy of radioembolization in patients with hepatocellular carcinoma. So as I mentioned previously, it is about 90% of the primary liver cancers, with an average survival rate between 6 and 20 months. And the most recent guideline was updated in 2022. However, it only gives recommendations about single lesion hepatocellular carcinoma, which are smaller than 8 centimeters. First-line therapies include resection, ablation, transplantation, and with these treatments, the expected survival can be more than 5 years. However, if they are not feasible or fail due to any reasons, there are, thankfully, other alternative therapeutic options, such as the transarterial chemoembolization or the transarterial radioembolization. Due to the lack of guideline, there is an unmet need for the treatment of single lesions which are larger than 8 centimeters, so we would like to investigate this question in this specific patient population. We are using the PICO framework again, and we hypothesize that treating single lesion hepatocellular carcinoma larger than 8 centimeters with radioembolization is at least the same safe and at least the same effective as treated with other types of locoregional or systemic treatment. The clinical implication here would be the improvement in tumor response rate and in the improvement in overall survival. To quickly summarize my two projects, the first one is planned to be submitted in this year, September, and the second one in May 2026. As a closure of my presentation, I would like to quote the words of Barbara McClintock: "If you know you are on the right track, if you have this inner knowledge, then nobody can turn you off, no matter what they say." Thank you for your kind attention.
Thank you very much for keeping the time quite much.
Yes. I thought it was be longer, but okay.
Questions?
Congratulations. It was really interesting. So I have many questions. So the first one, what is the preferred technique to calculate the liver remnant?
So this future liver remnant is calculated or measured with imaging-based volumetric assessment. So basically high-resolution, contrast-enhanced CT, and also MRI performed. And also, so there are specialized and dedicated softwares which can calculate the volume of each liver segment. And there is also an option for the functional assessment. It is measured with technetium macrophenib hepatobiliary scintigraphy, where they evaluate the uptake and the excretion of the radio tracer. So it reflects on the functional reserve capacity of the liver. And there is also another test, the indocyanine green test, but they are all functional. So it can be approached by either a functional aspect or by volumetric aspect. And I think, I'm not a clinician yet, but I think both of them are almost equally important. But yeah, that would be my answer.
And the second one is, what is the delay between the radiation therapy and between the surgery? What time is it?
So currently, that's why I think eye research is very, not just novel, but very interesting, that currently this radioembolization is used for bridge to transplant, but now we are investigating if it's good enough to be bridge to surgery, not for transplant, but for surgery. So they are using in first line the venous deprivation techniques, what I mentioned. And sorry, what was the question? I just wanted to give a background.
You mentioned that it could be a bridge
yes.
to the surgery, and what is the bridging period or something?
Yeah, so in the articles, what I've read, I would say 3 or 4 weeks, maybe 2 weeks. So it happened before that this venous deprivation technique was performed, and after the intervention, 2 weeks after the intervention, the surgery could be done. But of course, time here plays a very crucial role. So I would say between 2 and 4 weeks, the surgery can happen. Of course, if the future liver remnant is big enough, because sometimes these interventions are not sufficient enough, and it may happen that another round of intervention is needed to achieve that growth of the liver remnant, and that delays the surgery, unfortunately.
Okay, and the last one, I promise the last one. So regarding the second project, so did you include immunotherapy? Because currently there are excellent results as a comparator to your technique. So because we have excellent results with immunotherapy.
Yes, I think we will. We haven't decided precisely and exactly what to compare and how to form the groups, but I think we will, because as you mentioned, it's important and it's used. So we would like to expand that as wide as we can, I think. Yeah.
Thank you.
I have just one short question. So is radioablation performed differently for the purpose of a therapeutic intervention versus just to induce basically hypertrophy?
No.
Or is the same, like the same focus and the same?
Maybe so the focus is the same, what you mentioned, right? I think the dosimetry can be a little bit different, maybe the activity that is administered, but in profound it's the same, yeah. So it doesn't really matter with which aim we perform it. It's the supplying arteries of the tumor are occluded with microparticles loaded with radioisotopes, and it's always the same route.
So I have a small comment for your first project and 2 questions about your second. So in China, stem cell therapy is also used for exactly the same reason. And I think you should include this in your systematic review as well. Yeah,
well, thank you for your comment and question. Yeah, I come across these articles, but as I remember, they not solely used stem cell infusion, but with combination in portal vein embolization, and we included them. So that's the first thing.
Very good. And the question about your second topic is, why do you think this intervention is not recommended by guidelines? Is it because nobody thought about it, or?
Yeah, so here I think that the size of the tumor is a limitation here. I mean, in most of the cases, the patients got diagnosed when it depends on, of course, but it usually takes more time to get the tumor so big, like bigger than 8 centimeters. And with this radioembolization, there hasn't been enough tries, haven't been enough efforts to find it out, figure it out. But I think the future is that there will be more evidence, and thanks to researchers and young scientists, there will be more data, which can, yeah.
And isn't it an ethical concern that this is going to be a retrospective study? Isn't it going to be an ethical concern when patients whose data have been used for the trial figure out that they have actually received an intervention that wasn't recommended by a guideline?
Yeah, thank you for the question.
It's a difficult question.
Yeah, and it's valid, I think. Yeah, it's very good, because if it also, so usually these patients don't get this radioembolization in the first line, so they get either surgery or immunotherapy or other chemotherapy. So at the first line, I would say it's not a first line therapy, but a second line, and that's an important thing because they received the therapy which was available at that time, and regarding the most updated guidelines, which was the best for them and which was available at that time. But yeah, we have to think about it. I mean, yes, and of course in the article how to conclude it, and yeah. Thank you very much. It was very
Thank you very much.
Thank you.
Thank you.